Good day, all, and welcome to the Teledyne Pulse podcast, your Rural Health Matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
Hello, and welcome to the Teledyne Pulse. This month, we're bringing you a two-part series excerpted from a webinar we had in February of this year. In the webinar, Dr. Allison Nazinitsky talks about infectious disease via telemedicine and shares some of the most interesting cases that she's run across. We hope that you enjoy it. If you'd like to follow along with the slides that she presented, they're available on the Teledyne website at teledynehealth.com. Pull down from the resources menu and look for webinars.
Welcome, everybody, to our first webinar of 2024. I'm really excited to have Dr. Allison Nazinitsky with us, or Dr. Naz, as we like to call her. She has got some really fun cases to review today. We've known Dr. Naz for, 3 or 4 years now. Been great to work with her. Patients love her, providers love her. It's just been a great relationship all around. So, Dr. Naz, I will kick it off and hand it to you, and you can tell them a little bit about yourself and the things you have to talk about today.
All right. Well, thanks everybody for joining my webinar series. I titled this Case Potpourri because I'm going to go through 6 cases, maybe too fast, hopefully not too fast, so everybody can listen. But I just want to share my excitement for telemedicine, infectious disease, and the benefits and how much I've enjoyed this, and hopefully share that through the case series that I have in store for you. A little bit about myself and how I got into telemedicine, infectious disease. So I did my fellowship from 2013 to 2015 at Washington University in St. Louis. In 2017, I made a transition into travel infectious disease where I did locum tenens work, traveled all over the country. I then got into telemedicine through that. With all my state licenses, it made it easier to get into telemedicine. I have worked in over 50 hospitals with more than 10 EMRs. I lost count after all the hospitals I have on my CV. I do have 16 state licenses. And my favorite part of telemedicine is that I get to be part of the team all across the country, and I get to see the best of every part of healthcare and also the worst, but mostly the best. And I get to take the best of every network and every hospital and get to share that with the other hospitals that I'm covering. And I get to work with every part of the healthcare team. So hospitalists, primary care doctors, pharmacists, nurses, all the microbiology labs that we work with. And then of course, our telemedicine team. It's just been such a great team, very collegial. And that's the most, and then obviously the patients too. But and then everybody likes to ask me, what's my typical day like? And I really don't have a typical day. It depends on which hospitals I'm covering and in what capacity. But I would say on average, it's anywhere from 1 to 30 plus patients a day, depending on which hospital that I'm covering. So a little bit about what is telemedicine infectious disease. So we have consults where I do synchronous consultations where there's a video cart, a nurse or a telepresenter will wheel me into the room. I get to talk to the patient, interview the patient, put in my own notes, put in my own orders, and discuss with the referring physicians. And also some asynchronous consults. So I'm not a big fan of curbsides. I really like to read about the patient, have all the information at hand. So an interprofessional consult, I can look through the chart, put in a note, and then discuss with the referring hospital. And even though I'm not directly involved with the patient, I'm able to give really high-level recommendations for that patient. I do mostly inpatient, but there's sometimes some outpatient questions that come about. I also do telemedicine stewardship. So I work with MD Stewardship to join the meeting to provide stewardship across the country. And the most common diagnoses, there's a lot of them, but cellulitis, osteomyelitis, diabetic foot infections, prosthetic joint infections, meningitis, bloodstream infections, including endocarditis, complicated pneumonias like empyemas or parapneumotic effusions, complicated UTIs, abdominal abscesses like perforated diverticulitis cases, multi-drug resistant infections, and then patients with multiple drug allergies where we're limited in what we can use. Really, what I like is to be able to keep patients local, reducing the patient transfers, decreasing readmission and decreasing length of stay and mortality, decreasing hospital-acquired infections, and then reducing antibiotic use, which overall decrease costs, toxicities, and then just improving the quality and improving patient safety all across the country. There are certain diagnoses like Staph aureus bacteremia, where it's been proven to have an ID consult has improved mortality, and being able to offer that across the country where there's no infectious disease doctors is really important to me to be able to provide that care. So this is a map of the United States, and in the white is where there's no ID physicians at all. So they say 80% of counties in the United States, and you can see the Midwest really is the predominant of this area that's white, does not have access to infectious disease specialists. So being able to cover not only the tertiary care centers, but a lot of the rural hospitals is really important to me to be able to provide expertise to these patients. And then the shortage is really not going to get any better anytime soon. So this is the match results from 2024. And as you can see, only 303 fellows matched this year. There probably will be more after the match, but pretty low numbers. It ends up being about 6 ID doctors per state. But some of the bigger states like Massachusetts and New York and California, they might have 15 or 20 that end up staying there. So really leaves very few ID physicians for the rest of the country, especially rural healthcare. And so out of the country, these are the states that I cover the most in. So all over, I get to see East Coast and West Coast and South, all over. And then in Nebraska, these are the cities I get to cover with tele-ID through various modalities. So just trying to show a breadth of how many hospital systems I'm involved with. So I want to get started with some cases here. So this is case 1. This is a 35-year-old female. She presented to a critical access hospital with headache, fever, confusion, and altered mental status. And her history was that she recently went hiking in Colorado Springs 3 weeks prior. So headache and fever, we always get concerned for meningitis. So that's the route that they went down in the ER. And this is a critical access hospital that does not have tele-ID. So I actually got called as I was covering a tertiary care center that they were considering transferring this patient, and they wanted to run the case by an ID doctor before they transferred her. So they did a lumbar puncture at this hospital before transfer. She had 286 nucleated cells, 68% lymphocytes and 22% neutrophils, and then an elevated protein. So an aseptic meningitis picture. They had some rapid diagnostics at this hospital, which is good. Some of the smaller hospitals don't have in-house testing, but their rapid PCR panel was negative, and then they were able to get a gram stain back. And it was had 4+ white blood cells, but no organisms seen. She did have a CT scan of her brain, which was negative for any acute findings. And then this came back after she was even discharged, but it just showed mature lymphocytes and no evidence of malignancy. So meningitis is especially aseptic meningitis is a good diagnosis that can be kept local. Oftentimes physicians and patients really get worried, even if there's more than 10 cells in the CSF, it pretty much automatically results into an ID consult to see what's going on. So in some of these cases, like aseptic meningitis, it allows patients to be kept locally, because sometimes if we can do an expedited workup and manage them locally, they don't need to be transferred, especially if there's no complicating factors. So when I get called from an outside hospital, or when I'm first assessing a patient with meningitis over the phone, the first thing I ask, are they having seizures? Do they have signs of hydrocephalus? Have they had recent mastoiditis or ear surgery? Do they have poor dentition, where we're thinking their teeth have possibly eroded into their CNS? Do they have genital lesions? Do they have a diffuse body rash? Things like syphilis can have rashes involved, or some of the mosquito-borne or tick-borne illnesses. So I always ask these questions before, to make sure we're doing everything we can for these patients. And if they don't have these complicating factors, no seizures, no need for an EEG, really they can be kept locally. And we can do tele-neuro consults also in the local hospital. So rapid diagnostics are very helpful, but sometimes limited in some of the smaller hospitals. getting a CT scan to rule out hydrocephalus or mastoiditis or some of these complicating factors, and then always getting the basics on your CSF, including an opening pressure. So this lady ended up having West Nile virus and meningitis. Her CSF IgM was positive and her serum IgM was positive. And she was transferred. So I saw her upon transfer, and the diagnosis was fairly clear just based on her history. And she had already started feeling better. So we gave her symptomatic treatment with analgesia and some fluids and stopped all of her antibiotics. And then she felt better and we sent her home. But we definitely could have kept her locally with just tele ID. And I know her and her husband were very comfortable being transferred, but definitely could have given her the same level of care at her local hospital. So this is case number 2. This is a 45-year-old female. She has a history of hypothyroidism. She has a history of recurrent MRSA boils, and she presents to an outside hospital. This is actually over the state lines of where I was practicing, with shortness of breath, fever, and cough. And she was initially treated with steroids and sent home. She had worsening hypoxia and came back to the ER and had some antibiotics and a CT test. And basically they thought it was a viral illness because her husband and her son were also sick at the same time. They were all having the same symptoms. So she was just given more prednisone and sent home. And then the next day, she came back and now was hypoxic down to the 70s. Her labs were her white count was a little bit elevated, but of note, her liver enzymes were very elevated. And then she was transferred for pulmonary and infectious disease consultations. So I was not involved with the transfer process. I was covering a tertiary care center this day, and I was called directly from the pulmonologist and the hospitalist to give me a heads up. Hey, this lady's very sick. We are very concerned about her. Can you see her right away when she gets admitted? And so this was her initial chest x-ray. So she had moderate diffuse pulmonary opacities seen with pneumonia, edema, or ARDS. And upon transfer, so they had already gotten some history from her before I even saw her. So she works as a nurse and she lives on a farm, and her family recently cleaned out her barn. Very interesting. And this is her CT. So she's got these diffuse ground glass and reticular nodular opacities, and this is throughout her whole lung. She's very sick. She's on BiPAP on admission. And so at this point, the differential is this viral because she's got multiple sick contacts, bacterial, fungal. Could this be non-infectious inhalational pneumonitis? But her barn exposure, I think we were all concerned for histo was our biggest working diagnosis. And I can't take credit for that diagnosis. I remember the pulmonologist calling and saying, I think this is histo. But so right when I saw her, I was able to be wheeled into the room on the cart and talk to her and her family. And I said, look, we're all concerned that this is a fungal infection. I think we need to start this medicine called ambisome. And there's a lot of toxicities with ambisome. And we don't just give it out like any antibiotic. It's a very serious antibiotic. And so I counseled them and I said, let's start you on ambisome. Let's get a workup going, but we need to start treatment as soon as possible. Very, very sick, on the verge of intubation. They were able to do a bronch without putting her on the vent. And her pneumonia lower respiratory PCR was only positive for coronavirus, but this was not COVID. This was just one of the other coronaviruses. And then over the next 4 days, with steroids, some antibiotics, and ambisome, we were able to wean her down to 2 liters. And then by hospital day 4, we actually got a diagnosis. So, I kind of gave it away in the beginning, but this lady was immunocompetent, had no HIV, was not on any sort of TNF inhibitor, no chronic steroids, very immunocompetent with primary acute disseminated histo. So this is pretty rare. And so her bronch ended up growing histo, and then her serum and urine galactomannins were off the chart positive. And so this is the other part to this, is that by hospital day 6, she was off of oxygen and she was able to be discharged home to continue her home infusions. And this was across state lines. This was all coordinated with the ID docs there and the case managers. And then she was then transitioned to itraconazole, and she's doing well. And I would say this is a world record hospitalization for how quickly someone got better with how sick they were. And it was because of the team efforts between, well, not just myself, but the pulmonologist, and really the communication that went on between the hospitalist, pulmonary, and then the referring hospital, and then telling me exactly what I needed to know, that everybody was concerned for this fungal process, which sometimes doesn't come to light for a couple of days in the hospital, but everybody had talked to the family and gotten this history. So I wanted to share that case because of those reasons. So this is the third case. This is a 60-year-old male with methamphetamine use, and he smokes methamphetamines. He has very poor dentition, and he presents to a tertiary care center, regional referral center, with altered mental status, headache, and fever and confusion. So kind of along the same lines as the first case, we get a lot of calls for possible meningitis or CNS infections. His initial white count was 17, hemoglobin 9.9. His chest x-ray showed a small infiltrate in the left upper lobe. And he was really sick. So he got intubated in the ER. He got a CT of the chest. This shows a nodule in that left upper lobe. So it's more of a nodule than like a focal infiltrate. And then they did do a CT of the head. And then this is his MRI. So he's got 2 areas of abscess in the right parietal and temporal lobe, and then the medial left occipital lobe. So pretty extensive. And I don't know why it says case 2, but very extensive amount of cerebral edema. You can see midline shift. And fortunately, this hospital has neurosurgery present. So in the ER, patient underwent a emergent left frontal ventriculostomy and had in his spinal fluid almost 58,000 white cells, and of those 64% were neutrophils, and his protein was greater than 600. And then his gram stain was negative for any organisms, many PMNs. And then he underwent an emergent right posterior temporal parietal craniotomy and had resection of this brain abscess. And then this is from the lab. So he had gram-positive rods on his gram stain. He was intubated with a ventriculostomy drain in the ICU for a few days. He had the heavy growth of these gram-positive rods. And then we got pathology back pretty soon because they were initially concerned about cancer. So we got marked acute inflammation with some tissue destruction, and then gram-positive branching filamentous organisms suspicious for nocardia. And so anytime we get this gram-positive branching filamentous organisms, we call these BFOs in ID, and all ID doctors get really excited for BFOs. And so I was like, oh, this is so exciting. And so this patient was already on broad spectrum antibiotics. And then I was able to work with the lab at this hospital to get all of his specimens sent out to reference labs and make sure that they were going to get full identifications and susceptibilities, because right now we didn't have a good idea of what was causing this. Could this be nocardia? Could this be something else? And so I initially had him on broad spectrum antibiotics covering the typical organisms we see in brain abscess. But after the nocardia came back as possible nocardia, I adjusted his antibiotics to ones that cover more nocardia coverage, and was able to work with the pharmacy to order in some of these other agents. So his brain abscess ended up growing 2 different organisms, a biotrophia and a granulocatella. And then his CSF ended up growing nocardia. So very interesting case. He's still in the hospital, and he's in acute rehab right now, and I'm still awaiting the susceptibilities for these organisms. But he's doing very well, and I have him still on broad spectrum antibiotics, and I've ran this case by several other folks. This patient had 2 negative HIV tests. He's never been on any medications. So assumingly he's immunocompromised from probably extensive meth use, but very interesting case. So nutritionally variant strep are these species, A. biotrophia and granulocatella. They're part of the normal flora of human respiratory tract, so probably from his poor dentition. And they're very difficult to culture in the lab. So they can look all different shapes and look pleomorphic. They can be gram-positive, gram-variable, and so difficult to identify, and also difficult to gram stain and get a characterization. And then nocardia, these are gram-positive aerobic actinomycetes, and they can cause localized or systemic infection and can disseminate to the CNS. 1/3 are non-immunocompromised, and then they can relapse despite appropriate therapy. And there's 54 strains that can cause disease in human. Of those, 14% are the same strain that was isolated in our patient. So he's doing well. And I wanted to highlight this case first off because it was very complicated with working with the lab and adjusting the antibiotics covering these organisms. But also this patient was pretty, he doesn't have a lot of resources, and he had family at his bedside, at least four to five family members every day that I saw him. And they would never have been able to travel 3 hours away to the nearest center with an infectious disease doctor. So the fact that they were able to keep him local was just great for the family too, to get him through this, because they were at his bedside every day until he was, well, they're still at his bedside because he's still in the hospital. But I think that was one of the most important parts too for this case, from this case, to highlight, is that there was just no way that this family would have been able to travel to see him without having tele-ID being able to be by his side, and having families support these patients and their loved ones is really one of the most important parts of getting patients better.
Join us next time as Dr. Nazinitsky wraps up her case reviews. We talk a little bit about ID telemedicine in rural and regional facilities, and we take a few questions from the audience that was viewing.
We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired, or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledynehealth.com. That's pulse@teledigmhealth.com. For more information or general inquiries, please visit teledynehealth.com.